Hello, let's learn about Clostridium difficile infection prevention. Clostridium difficile, the term itself means difficult to treat and detect. So it's a very serious issue of Clostridium difficile infection in healthcare settings. How is the process of Clostridium difficile disease get transmitted? The chain of transmission is that the infectious agents such as thrives because of the irrational antimicrobial therapy or incomplete disinfection or sterilization. And the reservoirs are because of the engineering controls, environmental cleaning and disinfection, improper food storage and others. Portals of exit is through to the contaminated hands, and modes of transmission to contact route. And if you want to break the change of transmission, if you want to control the question of infection, we will need to break the change of transmission. And to break the change of transmission, we need to follow proper contact precautions and environmental hygiene. Hand hygiene is very essential. Follow contact precautions like wearing gown and gloves for care of patients with Clostridium difficile infections. Identify the cases and have appropriate use of antibiotics. Environmental disinfection is equally important as hand hygiene and needs to be stringently followed. What is the takeaway from guiding documents? The cases are on the rise. Clostridium difficile spread is complex. The EPA, that is Environmental Protection Agency, registered sporocidal must be used for C. difficile disinfection. C. difficile management is multifactorial and multi-collaborative. State concerns and concerns from the studies because of the role of the community cases, role of asymptomatic carriage, human factors are errors. Perform environmental decontamination of rooms of patients with Clostridium difficile infection using approved sporocidal product in an outbreak or hyperendemic. What are the drivers for Clostridium difficile management plan? Occupational safety health OSHA guidelines, then guidance document, then healthcare facility policies, infection control best practices, safety data sheets, organizing culture, and local epidemiology contribute to the infection control strategies for Clostridium difficile. We know lots of guidance documents are there. We know how to fight Clostridium difficile. There are many guidance like guide to prevent these infections, best practices for environmental cleaning. The impact is there has been rise in the healthcare associated Clostridium difficile infection, as well as we are observing community associated Clostridium difficile infections. The point prevalence study done was observed that 4,50,000 annual Clostridium difficile infections take place. 29,000 are attributed deaths annually. The trend is 10-year respective discharge chart revealed that the incidence of Clostridium difficile infection is nearly doubled in the last decade. Literature evidence of improvement is being observed. Transmission rates are not it's not following because of the outpatient challenges, inpatient challenges, and they both contribute to Clostridium difficile spread through sources in the community, and spores are everywhere, like pets, water, soil, infants, outpatient antibiotics, food sources, and parasites. 25% of the general public test positive for Clostridium difficile. They get succumb to the infections. Why rates not following because of outpatient challenges, inpatient challenges, the challenges into the difficile because of complex transmission, tenacity of the C. difficile, microbiology testing, environmental contaminations, infection control lapses, and role of asymptomatic or close transmissions. To complete up to 50% of people admitted to hospital could be Clostridium difficile positive. 50% of surfaces in the healthcare setting, patient rooms were positive are positive after cleaning also. There are delayed isolation and detection of the C. difficile. So 50% of adult inpatient tested were positive for C. difficile. 10 in 20 on hospital. There is an increase in the resistance also among the Clostridium difficile. High room occupancy, a new admit to an environment that housed prior positive patients and Clostridium difficile positive patient who was moved to a new environment are leading causes for and there is up to 50% of chance of the other patient developing the Clostridium difficile infections. Current environment cleaning practices fail to reduce the risk of acquisition of spores, and it can be airborne to up to 48 hours after discharge of C. difficile patients. Receipt of antibiotics by prior bed occupants were associated with the increased risk for C. difficile. Stool management, that is C. difficile, was recoverable from air sampled at heights up to 25 centimeters above the toilet seats. Contamination could permit transmission of C. difficile from asymptomatic carriers, and thus explains some CDI cases where no apparent link CDI cases are found. Lidless combination toilets increase the risk of C. difficile environmental contamination. We suggest that the use is discouraged, particularly in settings where C. difficile is There are multiple players in cases where we have used spore disinfectant. Is there ever a delay in a setting switch to spore products? Are there any gaps that failure used to spore agent facility percentage? Asymptomatic carriage, that is C. difficile exposure and acquisition from antimicrobials and additive to healthcare facility composition are leading to colonization of the healthcare professionals and the patients with no symptoms, and some of them succumb to infections with symptoms. Current guidance suggests isolation should continue until 48 hours after the diarrhea resolution, and because data is shown that the potential for transmission persists up to 8 weeks. Outbreaks have been linked to asymptomatic patients, and one third of the transmission arises from asymptomatic carriers, and there is a severe underestimation of the role. 45% of Clostridium difficile cases are genetically unrelated. What are the diagnosis challenges now? As said before, difficile is difficult to treat. So we have different characteristics of the stool charts here in slide. The diagnosis and the challenges include say, the fecal samples are time consuming to obtain wherein the should reach the laboratory within an hour of collection, and also the tests like soil cytotoxin glances sensitivity no longer considered gold standard. Enzyme immunoassay are widely spread but lacks the sensitivity. Glutamine dehydrogen test excellent negative predictive value. Positive test necessary secondary confirmatory test to assess whether toxin is present. Now we have the toxin testing test by nucleic acid amplification test. They are highly sensitive specific, but they are expensive again. So there is no single test that can use as a standalone test for diagnosing CDI. Therefore, the use of a two-step Clostridium difficile was recorded on 49% of the sites in rooms occupied by patients with C. difficile, and nearly 30% of the sites occupied by asymptomatic carriers. Computer touch screens are the potential reservoirs of these opportunistic pathogens in hospitals. So cleaning instructions such as mild soap, lint-free cloth, and water increase the risk of infection transmission. Non-sporal agents have been shown to promote correlation of hypervirulence strains. Public research has shown that levels of the environmental decontamination increase so that the prevalence of C. difficile. To recap the challenges, there are the hazards from inpatient settings like asymptomatic carriers, non-sporal agents, Clostridioides tenacity, and toilet leaks. Missed lab diagnosis, poor hand hygiene compliance, missed care identification, and touch screen lint. Multiple sources of difficile infections, asymptomatic carriage is relevant, human factors is important consideration, better innovation of disinfectants are needed, guidance documents are up for renewal, universal sporosal disinfectant use is an effective control strategy. Thank you.